Mechanism of action, journey from pathophysiology to drug discovery. This episode is called Muscle Poisons, Malaria, and the Root of a Plant, the first pharmacological options for hypertension. Thanks for joining us for part 3 on our series focusing on hypertension. Now we're going to take a deep dive into some of the therapeutics that were offered to treat blood pressure. This is looking at the first pharmacological options to treat hypertension. The first episode was an overview of the gradual recognition of elevated blood pressure being a problem, which really came into light in the 1960s with the Framingham Heart Study. The second episode, I talked about non-pharmacologic management that recognized if you bled people, their blood pressure lowered. If you know anything about the history of medicine, that was not a surprise. We bled people for a lot of reasons, especially used in the management of patients with heart failure, where their heart was not able to pump the fluid out and the fluid built back. People got pulmonary edema or fluid in their lungs, or they got fluid back up in their lower extremities, and they would have kind of edematous lower extremities. Then we talked about salt restriction, which was really interesting. It had a lot of back and forth on the questionable benefits of salt, and it took a lot of trials to show that in some patients, salt restriction does lower the risk of hypertension. The rice houses happening out in Durham, North Carolina, diets high in rice seemed to be very popular for a while, and that was the interesting study. Now I'm going to introduce the first pharmacologic management options for the treatment of hypertension. We're going to focus on two of them, hydralazine and reserpine. I picked these two because they were some of the more prominent drugs, and you probably recognize that we still use both of those today. Hydralazine is much more common. Reserpine, I think, is more used in psychiatry, but hydralazine is definitely used today. And as a rheumatologist, I'm hyper aware of hydralazine because hydralazine can trigger autoimmune conditions like lupus and vasculitis. Also, those two drugs were used in the first major trial in 1967 done at the Veterans Associated Administration. It's called the Cooperative Study, actually looking at implementing antihypertensive medications in patients and see if that reduced the risk of cardiovascular disease. The study also added a thiazide diuretic, so that's too big of a topic to just throw in willy-nilly into a miscellaneous bucket. Thiazides are a cornerstone still in the management of hypertension, so they get their own special podcast episode where we'll dive into the history of diuretics and the history of chlorothiazide. I think you will enjoy that episode. But before that, we are talking about hydralazine and reserpine. So you might be wondering, what was the first pharmacologic treatment? Would you guess that it was well before 1950s and 1960s? You might not, right? Because as I mentioned, we didn't really recognize the dangers of having elevated blood pressure. So why then would companies make drugs to lower blood pressure? But don't forget, in 1928, they recognized in certain instances there was hypertensive emergencies where people with extremely high blood pressure in the 200s or 300s, with diastolics well above the 100s, they could have acute organ damage. The patient can come in with hemorrhagic stroke. They can come in with myocardial infarction. They can come in with kidney failure because of that high blood pressure. So there was some instances where people said, hey, probably lowering blood pressure would be a good idea in this situation. Regardless, it took a lot of pull and twisting of arms for doctors to recognize this. Again, 1950s, 1960s, were like, oh, that's clearly a good idea. But well before then, it was very, very controversial whether or not that was a good idea or not. We actually had the first indication or recognition that something lowered blood pressure before the 1900s. The first medication was sodium thiocyanate, which it sounds kind of like industrial chemical, which it kind of is. So it was used a long time ago. It was first described in the 1800s and regarded as a quote-unquote muscle poison to abolish muscle activity, not a ringing endorsement for sodium thiocyanate. Two people were studying the compound and noticed that in small doses it lowered blood pressure. I found a paper from 1936 that studied 45 patients giving varying doses of sodium thiocyanate and measuring blood pressure. Early in the study, 2 of these patients developed quote-unquote severe weakness, vascular collapse, and cerebral thrombosis. So that doesn't sound good. Both patients had severe hypertension ranging from the systolics of 250 to 275. These patients had very high blood pressure, and sodium thiocyanate led to vascular collapse. As you can imagine, this was not used a lot. The authors note successful and safe lowering of blood pressure did occur, but the sodium thiocyanate had to be monitored very closely. Now we're going to enter the domain of the drugs I talked about, the hydralazine and reserpine. And I'm going to give a little background on that VA Cooperative Study because it's pretty fundamental to understanding hypertensive management. So the first large-scale study was 1967, studying placebo versus intervention. And the intervention was reserpine, hydralazine, and hydrochlorothiazide. They recognized that the risk of stroke is directly related to the height of the blood pressure. This is in the introduction to the paper. For example, the Framingham data indicate that the incidence of stroke in men aged 45 to 54 years old was 10 per 100,000 with a systolic blood pressure of 110 to 119, and 37 per 100,000 with a systolic blood pressure of 160 to 169. The incidence was higher. The study was designed to try and see if interventions with medications could lower that risk of death, stroke, myocardial infarction, renal failure. The people who were enrolled were veterans with a diastolic of 115 to 119. So actually they're looking at the lower number, which again was very high. They followed up for about 1.5 years. They demonstrated decreased morbidity and mortality. Morbidity was recognized as fundal hemorrhage, cardiovascular accident, myocardial infarction, heart failure, or dissecting aneurysm. That study showed, hey, look, this intervention really makes a difference. Whether or not that really caught people's attention is a matter of debate. But a first well-done trial with hundreds of patients looking to see if this changed things, and the three drugs that were used were hydrochlorothiazide, reserpine, and hydralazine. One thing that I thought was a fun little anecdote about this study was the person who ran this study, a famous person, by the way, and I'll tell you his name in a minute, he recognized that how well could he trust people to take a daily pill? Again, this is the 1960s. There wasn't a whole lot of regular pharmacologic interventions for most patients. So a lot of people weren't taking daily pills, for example, let alone taking a pill for a asymptomatic disease. We still see that now. A good example would be, again, treating blood pressure. Patients don't feel their blood pressure being elevated, so they don't have a daily reminder to take the pill. Another example is osteoporosis. People who have weakened bones measured by bone scanning or DEXA scanning. You tell people they have a very high risk of fracture if they fall. Here, take this pill to reduce that risk, but they may forget to take the pill because they don't feel anything every day. It's an asymptomatic disease process, making people less likely to take the medication. So the lead author recognizes this as a problem. How can we trust these people to take either the placebo or the intervention pill consistently if these people didn't even really recognize that their blood pressure was elevated and whether or not that is a problem? He devised a fairly clever system to weed people out who they thought was non-compliant with therapies. He gave each potential patient a riboflavin B2 pill daily for a few days, then on 2 consecutive visits tested their urine. The clever part about this was riboflavin under ultraviolet light is fluorescence. He'd measure their urine and then run an ultraviolet light over it and see if it fluoresced. If it didn't fluoresce, that means the patient was not taking the pill. If it did fluoresce, they were taking the pill, and then they'd get enrolled. So imagine how many offices this took. I can imagine back in the day, patients putting up with this, but they did this trial. They measured their urine for fluorescence, and then they enrolled them into the placebo or the intervention. Why don't we talk about hydralazine first? So this actually starts with World War II and malarial treatment. The United States, we're finding in the Pacific Theater, and there's a lot of malaria and a lot of different islands out there. The U.S. military recognized that malaria could be a massive problem, and it could end up causing a huge amount of morbidity and mortality in the soldiers. Even if the soldiers survive the malaria, they're often sick and put out for weeks, and they cannot do combat. So they recognize, hey, we need to be able to control the malaria in these areas and give prophylactic anti-malarials to soldiers so they won't get malaria. No problem, right? We actually have a therapy for malaria in the 1930s and 1940s. The bark of a cinchona tree, which the active ingredient is called chloroquine. So you can just get the bark of the cinchona tree, grind it up, and give it to people, and voila, they won't get malaria. Well, problem number 1, those cinchona trees are in Java, an island in the Southwest Pacific. Why is that a problem? Well, because that island has been taken over by the Japanese. The Americans could not get the bark from the tree. Plan B was to work with the people who owned those trees. The company who owned the cinchona trees was actually headquartered in the Netherlands. So could we just go to the Netherlands, knock on the door and say, hey, do you have some of that bark from the trees you have over in Java? The answer was no, because the Netherlands were taken over by, you guessed it, history buffs, the Nazis. So we did not have access to the cinchona bark at all. The Americans went to their chemistry sets and figured out how to synthesize chloroquine. They got the actual chemical compound of chloroquine, did tons of different little tweaks to it to see which one would be the safest and best tolerated medication. When all these soldiers were in the Pacific Theater, taking anti-malarials prophylactically, people with rheumatoid arthritis and lupus started feeling better. And if they were lucky enough to survive the Pacific Theater and made it back home, it was actually pretty common for those soldiers to ask their doctors if they could have the chloroquine because they felt their joints felt so much better on it. That led to some multiple trials looking and showing that these chloroquine medications do help certain autoimmune conditions like lupus and rheumatoid arthritis. It was decades and decades later that they actually realized the mechanism of action and why that's happening. Then we get a medication called pentequin. Pentequin was an effective anti-malarial, and it was given to soldiers during World War II. Something interesting happened with pentequin, though. When it was taken and soldiers stood up, sometimes they would pass out and slam their heads against a table, or they just feel really dizzy and have to sit down. The soldiers develop what's called postural hypotension, where they would actually feel dizzy and it seemed to lower their blood pressure. And when they stood up, you need a slight sympathetic reflex to increase blood pressure to keep that volume of fluid perfused in the brain. Because when you stand up, gravity takes all your volume down to your legs. So you need those vessels to clench a little bit and increase that pressure to keep that brain perfused. The vessels are all dilating. That causes that dizziness to happen. Doctors were pretty interested in this, and they started measuring blood pressure in these patients who were taking pentequin, and they recognized that it actually dropped pretty considerably while on this anti-malarial. This spurred some interest because we didn't have a whole lot of options. Then we get to Dr. Edward Fries. Edward Fries is the person who led that VA study, the Cooperative Study. He's a big deal in hypertension. He was coming out of Boston University at the time and who wanted to present more data on the use of this anti-malarial. He wrote this paper called The Effect of Pentequin in Patients with Hypertension, and 17 patients were evaluated. It's kind of wild, but for the procedure, the patient would get admitted 3 days prior to the medication to be started in a controlled environment. They'd control the fluids, control their diet, control their salt intake, and measure the blood pressure daily and calculate mean arterial pressure, which is an easier way to measure systolic and diastolic blood pressure. On that medication, they recognized a decrease in 10 to 40% in the patient's blood pressure. But the effect varied markedly. Some patients had significant hypotension. Some people had mild lowering of blood pressure. So it's a little unpredictable on how much blood pressure lowering that people would experience. The following symptoms typically accompanied the lowering of blood pressure: abdominal pain, tenderness, back and chest pain, facial pallor, anorexia, nausea and vomiting, constipation or diarrhea, and occasionally fever. This isn't sounding too great, not a ringing endorsement. Methemoglobinemia, which could be severe, occurred in 1 out of 17 cases, so not a great ratio. Agranulocytosis, another aggressive form of very low white blood cells, which could increase risk of infection. So not a whole lot of people were enthusiastic of pentequin, but they recognized this is some other mechanism that we don't understand that seems to consistently lower blood pressure. Maybe we should look into this more if we think people with very high blood pressure have a problem, and maybe this would be a relatively safe way to reduce it. Dr. Edward Fries went on to use pentequin in patients with malignant hypertension, and he recognized objective changes. The kidney function improved, their retinal findings on ophthalmologic exam improved on the pentequin. This was the first time someone showed an intervention in patients with malignant hypertension could reduce morbidity. They actually could have objective improvement in some of the organ manifestations of malignant hypertension. So this is a really big deal, right? There's got to have a lot of excitement behind the use of pentequin. Pharmaceutical companies started looking at anti-malarials and say, hey, can we tweak this compound to see if we can make it safer and better tolerated? Pharmaceutical companies got down to brass tacks and developed multiple compounds based off the structure of the anti-malarial. They found out the safest and best tolerated one, and they called it, drumroll, hydralazine. Hydralazine has been used since the 1950s, which I was surprised by. So the first medication was from an anti-malarial medication, which is pretty wild. Hydralazine was approved in 1953, and the first rheumatologist wrote a case report of drug-induced lupus 3 months later. I'm just kidding. I don't know when the first report of hydralazine drug-induced lupus was, but I'm sure it wasn't too much longer than when hydralazine was approved, okay? So it was used for decades relatively safely to lower the risk of cardiovascular disease, strokes, and kidney injury without really knowing how it works. It wasn't until the 1980s, so over 30 years after its discovery, that it was recognized to release calcium from the sarcoplasmic reticulum in arterial cells, limiting their ability to contract. Hydralazine was based on anti-malarial. So does hydralazine still treat malaria? Huh? Huh? No, it doesn't. I actually looked into this and it doesn't. That's just disappointing. Ooh, maybe all these patients are somewhat immune to malaria during all this. The answer is no. So what's the next drug I'm talking about? Reserpine. Reserpine was one of the first safe antihypertensive medications. I've heard the name, but I did not really know much about it. It comes from a dried root, Aruvolilia serpentina. I'm pretty sure I nailed the pronunciation on that, which was used for centuries in India for the treatment of basically whatever ails ye, from mental health to fever and snake bites. It was first used in the US in 1950, and its molecular structure was elucidated in 1953, but we didn't know exactly what to use it for or how it worked. Early reports of the use mentioned patients had some kind of degree of sedation and relaxation with a decreased heart rate when they're taking reserpine for whatever reason. A doctor by the name of Robert Wallace Wilkins, who headed the Massachusetts Memorial Hospital Hypertension Clinic, was looking for a compound to study for hypertension around this time. Dr. Wilkins said, hey, these patients feel more relaxed. Maybe their blood pressure will also decrease. Wilkins designed a trial for using the actual Indian snake root versus reserpine and noticed the same blood pressure lowering effects. He then actually proved that reserpine was the actual active compound within this tree root. In 1954, he wrote an article published in the Annals of New York Academy of Science, and he said, quote unquote, symptomatic improvement has been so marked in some patients as to be almost embarrassing to the physician. Many patients have become positively lyrical about their sense of well-being on the drugs. He was saying how these patients feel great, super relaxed. This is like giving like ketamine or something to people. They felt great. So Wilkins then promoted the medication to be considered for use as psychotherapy, as it was then called. A doctor in Columbia University by the name of Dr. Nathan Klein began using it on hundreds of patients in New York's Rockland State Hospital, noting marked anxiety reduction, relief of situational depression, a tranquilizing effect, and a decreased need for shock therapy. That's always a good thing, right? In 1955, the study was done in New Zealand. By the way, the study was sponsored by the Life Insurance Medical Research Fund of Australia. Here comes life insurance coming back in, trying to figure out a business around people's deaths. The study wanted to see blood pressure lowering effects on reserpine. They checked reserpine on patients with hypertensive versus normal tensive. The hypertensive patients had up to systolics of 260, so a little bit high. That's some sarcasm, by the way, that's really high. And then in patients with blood pressure in the 120s and 140s, or the normal tensive group, and recognized reserpine had a much greater effect on the hypertensive group, which is sort of a goal. You want it to help the people who needed it. The researchers wanted to better understand the mechanism of action of reserpine. How does it lower the blood pressure? The theory was that the direct vasodilator acts directly on the blood vessels to cause them to open up. To test this theory, they got 18 animals with big, adorable ears, which was rabbits. Why they use rabbits? Because of the thin skin of the ear, you can easily visualize the blood vessels, especially on albino rabbits. The rabbits underwent a cervical sympathetic trunk removal on the left side, so the nervous system in the left ear couldn't cause vessel contraction. Those poor little rabbits. And then they injected reserpine intraperitoneally. One ear at baseline had mildly visible vessels, whereas the sympathectomized ear had big plump vessels, remember, because it couldn't contract, likely because no sympathetic tone to cause vasoconstriction. Then after reserpine, the vessel that had minimal appearance suddenly had a big plump vessel. And the cervical sympathectomy already had a big plump vessel, didn't change at all. So the argument was reserpine has to work via the sympathetic parasympathetic route, as when the rabbit didn't have the nerves controlling the vessels, the reserpine had no effect on the vasodilation vasoconstriction. It was eventually discovered that reserpine interferes with norepinephrine, dopamine, serotonin, and histamine. It started being used as an antidepressant and actually played a large role in promoting the biochemical hypothesis of depression. We had a drug that interferes with biochemistry and people felt better. It was the first compound to ever demonstrate improvement in depression in a randomized controlled trial. During all this work, it was noticed to decrease blood pressure on people in the 50s and was a fairly established therapy. At the same time, the VA Cooperative Study came about. But you don't see it so much in use in medicine or psychiatry because a whole lot of other medications took over the role. So those were the first two of the three medications in the VA Cooperative Study. One, Hydralazine, came from the recognition that certain anti-malarial medications actually caused soldiers to pass out when they stood up. Someone saw this and recognized maybe there's something to that molecule and its role in blood pressure regulation. They pursued multiple compounds, eventually finding hydralazine. And then we get reserpine coming from a root and recognizing that it caused people to feel really relaxed. That led to the use of it and recognizing it clearly has some effects on various molecules like norepinephrine, dopamine, serotonin, and histamine. And that actually did lower blood pressure in patients. What, may you ask, happened after the VA Cooperative Study data came out? Was there an explosion of excitement about treating all these patients with hypertension with these three medications that clearly seemed very safe and effective, right? It lowered blood pressure in patients and decreased the risk of cardiovascular disease. So this sounds great. It's going to happen, right? No, probably not. An editorial came out a few years after the study, quote unquote. It would be expected that the result of these well-controlled therapeutic trials demonstrating the value of effective antihypertensive drug treatment in the prevention of stroke would be widely recognized and immediately applied by the medical profession. The available evidence, however, indicates the opposite. A recent survey by Schoberger on the employees of large downtown banks in Chicago indicates that only 11% of hypertensive patients found in the survey were receiving effective antihypertensive treatment. Yet the survey was carried out after the Veterans Administration's cooperative trial had been published. There was very little reaction from the media or from physicians, but more interest became generated when Fries, the doctor who led that trial, was awarded the prestigious Lasker Award in 1971. Meanwhile, philanthropist and health policy advocate Mary Lasker, armed with copies of the VA study, prevailed upon Elliot Richardson, Secretary of Health, Education, and Welfare, to establish a national program for high blood pressure education to alert physicians and the general public to the silent killer. In 1972, the National High Blood Pressure Education Program was started under the direction of the National Heart Institute at NIH. The campaign it launched made hypertension and its treatment a household word. It took a little while, right? But then people started really rallying behind it, and word got out that lowering blood pressure really helped people and reduce the risk of morbidity and mortality. It totally changed the face of how we approach people with elevated blood pressure. And now we have multiple therapeutics that can really impact people's lives and hopefully be very well tolerated. Probably the next biggest category is thiazide diuretics, or diuretics in general, which we delve into in the next episode, starting with mercury. Believe it or not, mercury was the first diuretic that was used, and it's used pretty commonly in people with advanced heart failure. And then we get ACE inhibitors, so that's going to be the episode after that, which is the big episode because we dig through the whole system of angiotensinogen, the renin and angiotensin system, all those discoveries along the way leading to the discovery of captopril. Thanks for listening to Mechanism of Action. We're a new podcast, so please tell your friends about us and like and subscribe. Give us a review if you can to help other people learn about the podcast. Thanks again for listening.